Today, we're going to discuss placenta accreta syndromes, the so-called invasive placentas. We will discuss the staging, grossing, and overall features of this interesting pathology of both the placenta and uterine corpus. Sit back and let's get started.
Okay, great. This is our first specimen of the day. So I will slowly move it around for everyone to see. Very good, everyone. So this is a uterus and cervix specimen. More specifically, this is a postpartum hysterectomy. As you can tell from such a large size compared to, as you can see, like from the scale and my hands. I'll take everyone through the anatomy. I think everyone kind of understood, kind of what the specimen is. So this being a total hysterectomy or a uterus with attached cervix. For orientation purposes, this is the fundal aspect or the superior aspect. Right now, looking at the anterior surface, this is the inferior aspect down here. Flipping it over on the posterior aspect, you can see the nice sort of smooth and tan serosalized surface. At the inferior aspect, you can see this is the exocervix with the os in the middle. Looking at this at the anterior aspect, there's a very nice clear landmark here, which is the anterior peritoneal reflection, which is one of the defining features of sort of like the anterior aspect of the uterus. It's a very useful landmark for identifying and orienting hysterectomy specimens. So we have a very nice example of it right here in comparison to the posterior aspect, which we have generally a very smooth, continuous serosalized surface all the way down to about I guess the next obvious question is to ask everyone the reason why this uterus was taken out.
Given that it's a gravid uterus or postpartum.
Can anybody in the chat tell me what are some reasons why a hysterectomy would be performed immediately after pregnancy or postpartum? Okay, leiomyomas, not so much. Postpartum hysterectomies at this level are usually medically emergency, or they're sort of like fairly critical in terms of procedures. They do it, fairly soon after the baby is delivered. Postpartum hemorrhage, especially when it's really bad. And yes, of course, placenta accreta, increta, and percreta. So like the sort of like the spectrum of invasive placentas. Very good.
Multiple, including, cancer is a good one too. But again, probably further down the list. Patient choice, of course, that's always an option.
Great. So this is a postpartum hysterectomy taken out for an invasive placenta. This is one of the main complications that arise with some women after they become pregnant. The placenta gets attached very firmly to the uterus. One of the main complications of an invasive placenta is it causes massive maternal hemorrhage, and it can be life-threatening, not just to the mom, but also to the unborn child. So obviously this is the reason why the hysterectomy was performed, right? And some of the additional landmarks you can see, if I turn the uterus up towards the fundal aspect, you can see this linear disrupted area. This is where the cesarean section actually occurred. So, these women who come in for these like complications, they require a big multidisciplinary team for support and care during delivery. The baby is extracted through this cesarean section site. Once the baby is safely delivered, then the surgical care team would then carefully perform a postpartum hysterectomy, where they attempt to take out the entire uterus and the placenta in one piece. And now that we've discussed what is happening in the uterus, can anybody in the chat, briefly explain what is invasive placenta and what is accreta, increta, and percreta? What do all these terms kind of mean for people who are not familiar? Great. Increta is very attached placenta digging into the uterine muscle. That's perfect. Thank you. Deciduous absent of trophoblasts invade into the myometrium. Good. So that's sort of talking about the pathogenesis of placentas invading into the uterus. Good. So accreta is attached, increta invades, and percreta perforates. Right. So that's great. Excellent.
That's
so
actually a very good mnemonic. That's the first time I've heard of it. Thank you.
Generally, placenta accreta, increta, and percreta generally describe like the spectrum of at which how deeply the placenta sort of invades. So accreta is sort of more superficial. Increta describes the placenta being invasive into the myometrium, and percreta demonstrates placental invasion through the entire thickness of the myometrium. we would see placental remnant on the serosal surface. And the placenta can even invade even further into the adjacent pelvic structures, such as bladder and rectum, depending on where the placenta is attached relative to other structures. So that's a very good mnemonic as well. Accreta is attached, increta invades, and percreta perforates. One of the mnemonics I learned when I was a student is A, I, and P in alphabetical order. A is more superficial, I is in the middle, and P at the end of the alphabet is later, so it's perforation. So that's the way I remember it as well. There are other methods of describing the invasive of placentas. One of the expert working groups have kind of come up with, and it's very similar to like the FIGO system to describe invasiveness of placentas, and they generally just split this up into several grades.
You want me to share this?
Yes, please.
All right. So further to that discussion, we do have a PowerPoint. So this is a recent paper last year, because you can imagine just having the AIP, creta, increta, percreta designations leaves a lot of room for interpretation. There was an attempt, as Will mentioned, about the FIGO grading, but this goes into more of an expert panel type of consensus. Okay, kindly share the PDF as well, but this is the one that came out last year from Modern Pathology. The idea was to kind of standardize the depth, and so there's an understanding or clear consensus in terms of what to call things. The grading is a bit more confusing, but in this paper, they talked about these different levels of proposed grading for what they're calling placenta accreta.
A sequence, yes.
Yeah, trying to move away from the accreta, increta, percreta names and instead using the different grades. From this diagram, I hope you can appreciate that there's different levels, including the grade 1, which is what you would call in the past accreta, grade 2, which is somewhere in the middle, grade 3, further down in the middle, but not involving the serosa, grade 3D and 3E are through the serosa, but just a matter of whether there's invasion of other pelvic organs. And then related to that, they also explained sometimes you can see this in the setting of a cesarean scar, and that usually correlates with a grade 3A, at least in their schematic. As mentioned earlier, histologically, the definition of an invasive placenta is really the absence of residual layer. So you've got either syncytial trophoblast or trophoblastic villi infiltrating straight into the muscle with the absence of decidua. This inset here shows villi straight into the muscle without any decidual layer. So that's the logical definition. Most of this you can kind of see grossly in terms of how deep, but just to kind of bring it back to histology, there is a strict definition for this.
Great, that's awesome. So this brings us to our first poll question of the rounds. Using this sort of new proposed method of grading the placentas, based on what you see in the specimen, which grade would you classify this specific postpartum hysterectomy?
I'll put up the schematic again so people can relate to it.
Grade 1 is classified as sort of non-invasive. The placenta is just grossly adherent and can be removed by manual palpation. Grade 2 is superficial invasion, where there is myometrium invasion with at least preservation of 25% of the uninvolved myometrium. Grade 3 is like increta, except there is no serosal involvement. 3D is deep invasion with disruption of the serosa, and 3E is deep invasion with adherent extrauterine structures, such as bladder and rectum. Thank you, everyone, for participating. This is very good. I think the majority of the participants did come to the conclusion that it is indeed, I would classify this as grade 3D, which is deep invasion with disruption of the serosa. If we look at the specimen again, can they see the screen? Okay.
Right.
If we go back to the specimen itself, looking at the lower uterine segment of the anterior aspect, you can see this big disrupted area. And this is actually placental parenchyma that's kind of poking out. Okay, you can see the difference. This is soft tissue from the uterus, and then you get this big disrupted area with the placental parenchyma poking out. So we're at least at a grade 3D. It's possible that we have 3E as well, but since we don't have any adherent structures present in the specimen, we can't make that call. Okay. Very good. I think this is a good way to talk about some risk factors for why some women are more prone to having problems with invasive placental spectrum. So which of the following are risk factors for invasive placentas? Please select all that apply. Awesome, everyone. Great. So generally for risk factors, like previous C-sections and uterine surgeries are by far the most common risk factor for invasive placentas. And the other four below, previa, advanced maternal age, multiparity, and as well as like Asherman syndrome, are also risk factors that increases the chance of invasive placentas.
What's Asherman syndrome? Just to enlighten people, if someone can kindly explain. It's a scarring type of process due to whatever etiology. So it's all related, either instrumentation or previous C-section or some other reason why there's extensive scarring and adhesions within the uterine cavity. That's basically distorting the architecture of the cavity such that you can have abnormal placentation in that area. So yes, it's all kind of related. Thank you.
Thank you, everyone. So I think this is probably a good time to get into, talking about how to approach and gross this kind of specimen. Sometimes these specimens can be a bit daunting, due to its fairly large size, but really the approach for grossing these postpartum hysterectomies, especially when you have a placenta that's in situ, it's really you're just combining a basic gross protocol for a total hysterectomy and a gross approach of the placenta, and then you're just kind of combining the two. The important thing to note when you're approaching these specimens is to pay attention to the interface between the placenta and the uterus, because that's really the most important part, right? Because we want to properly document the relationship between the placenta and the uterus and how far the placenta is invading into the myometrium, if at any. So starting off with the basics, you always start with your main measurements and the weight of the specimen. Weigh the specimen entirely. Your general measurements would include the superior, inferior, medial, lateral, and anterior, posterior measurements of the uterus, your cervix in at least 2 dimensions, mention the size and the shape of the os if you can. And normally when you approach the uterus, you would open the uterus sort of coronally on 2 halves and have the anterior half and the posterior half. But because you have a placenta that's in situ, one of the recommendations is that you don't open the uterus as per usual. One of the important things is that you want to preserve, the serosal aspect of the uterus as much as you can, so that you can properly assess the relationship between the placenta and the uterus. One of the recommendations I would ask for people to do is to do concentric cross sections transversely, the lower uterine segment all the way up, and to keep the rings sort of intact as you kind of move up. So, for example, this is another hysterectomy specimen that we have, which we have previously cut. It goes this way. So this is an example of what you should kind of see after you've taken your transverse sections. So I'm going to pick up these individual slices and then.
That's my hand modeling for today.
So this is something that you can expect on cut surface. Actually, we got more than 2, but yes, sometimes they come in groups.
We're not here to brag.
So the section I have is a very good example of a placenta accreta, or grade 3D. You have a firmly adherent placenta, and right here, you can see the myometrial interface. Thanks. You can see the myometrium kind of taper off, and then it just disappears. And then all you have left is the placenta that occupies pretty much the full thickness of the uterine wall, stretching from the endometrial cavity all the way to the serosal surface. So, sometimes like when you talk to PAs, we talk about the money section, the one section that defines and helps you stage the entire specimen. Like this is pretty much your money shot right here. If you take a section to document this, where you would have the placenta, you've got a little bit of the myometrium left over, and then clearly the placenta going through and abutting the serosal surface. So this would be a great section to take. Okay. Again, after you've cut these concentric rings, don't forget to measure your placenta in 3 dimensions as best as you can. You may have to do some reconstruction to get the superior inferior measurements. There'll be other additional structures to kind of like make note of, including like the insertion of the umbilical cord, how long is it, etc. Describing the fetal surface, the cut surface of the placenta itself, as well as uninvolved endomyometrium, where you can see there's some old hemorrhage, some organized blood clot, as well as some newer blood clot down here.
That's a very nice shot of a clot, an organization.
Actually, that's a good question. So I think these are just little vessels there. They kind of look like little umbilical cords. I don't have the umbilical cord here with me, but yeah, there are other recommendations in terms of what else to include in the your gross description. If everyone has a moment to go through the article, they also include a very helpful table where they prescribe other important things to note in your gross description, such as the percentage of invasion of the placenta, as well as location and the area of disruption of the serosal surface. So there's a couple additional things that are nice to include in your gross description to help properly document whatever is happening.